The learning objective for Lesson 6, now that we've collated the data, is to analyse the data in an actual case series in order to apply the Bradford-Hill criteria. So let's now look in more detail at all the evidence we have from the Vigibase reports. Who are the patients? What was the indication for omeprazole? What other illnesses did they have? There were 15 patients from 7 countries. In this slide you can see that 5 were males and 9 females. The age was late middle age or elderly. The indication was upper gastrointestinal disorders, so nothing that would cause renal failure or interstitial nephritis. None of the patients were reported to have other illnesses that might have caused or contributed to interstitial nephritis. As you can see here, omeprazole was the sole or only suspect medicine in 12 of the 15 reports. You'll note from this slide that information was not available in all of the reports for all of the variables, such as dose, time to onset, etc. This is usual, and we have to be aware of this limitation. There were sufficient reports with information to show that there was not a strong dose-response relationship. The time to onset ranged from 14 days to 42 months, a wide duration, but the median duration indicated that most were a much shorter duration than 42 months, which was an outlier. Normally we don't exclude any reports, but in one case the time to onset was minus 4 months, so obviously we can't count that. What about concomitant or co-suspect drugs? There was no consistent pattern suggesting an interaction. 5 medicines that can cause interstitial nephritis were prescribed for 4 patients: bendrafluozide, indomethacin, diclofenac, dicloxacillin, azathioprine. Recovery for 2 patients was clearly related to omeprazole cessation and not the other medicines that might cause interstitial nephritis. They were continued. No concomitant medicines suggested the patients had renal diseases already. After considering the patients and the drugs, we now look at the co-reported adverse reactions. These include 4 reports of fever and 1 of renal failure, as well as other symptoms that might accompany immune reactions or renal failure. Finally, we look at patient outcomes. Half of the patients recovered. 1 recovered with sequelae. This was on stopping the medicine. 3 hadn't recovered, and for 4 the outcome was unknown. If we consider D-challenge, recovery occurred on D-challenge with no clear alternative explanation in 6 patients, although for 2 I was not entirely certain, so I've put this in brackets. Sometimes it's difficult to interpret the information. There was biopsy evidence for interstitial nephritis for 1 patient, and you'll remember that the National Centre had another one that was not yet entered into Vigibase in 1996. So you will see that now that we have the data together, that some is missing, and the Bradford-Hill criteria are not completely filled, but even so, a picture is emerging. Let's look at how our data fits with the criteria. We have strength of association. We have significantly more observed than expected case reports in Vigibase, and that is statistical disproportionality. The temporal relationship. There is a consistent time to onset in that interstitial nephritis during omeprazole use occurred within 1 to 7 months of starting treatment in most patients for whom this data was available. Also, in terms of a temporal relationship, there was a reasonable time to recovery. Over half of the patients had recovered or improved at the time of reporting. The reports were also specific. No concomitant medicines or histories indicated interactions or conditions that could have been an alternative explanation. Omeprazole was the sole suspect in most reports. In 2 of 4 reports where other potentially causal medicines were prescribed, the patients recovered when only omeprazole was stopped. We also had consistency. Reports with similar details were sent from 7 countries. And then biologic plausibility. Interstitial nephritis is a recognized typical adverse drug reaction. So now we consider the simple question: is there any other way of explaining this set of data? Is there any other answer equally or more likely than cause and effect? Take a minute to reflect on this question. Well, as we've said before, the logic is probabilistic. We weigh up all the factors, assess the probability or likelihood. In the reports we've looked at, there is no clear alternative explanation apart from omeprazole for interstitial nephritis in most of the reports in this case series.